Okay, we're going to continue with Chapter 43, Part 4, Immune Disorders. Let's take a look at types of immunity. This is going to be a brief immunity review. There's natural immunity, that's your intact skin, your body pH, and your natural AB from the mother. Acquired immunity, not well developed until 6 years of age. And then you have the humoral immunity. This job is to destroy bacterial antigens. And then we have the cell-mediated immunity. Okay, so let's look at the pediatric differences in immunity. Children are born with passive immunity. IgG is the only immunoglobulin that crosses the placenta. So babies usually have normal levels of IgG until about 6 to 8 months of age. Then the level slowly declines and does not reach mature levels until the child is 7 to 8 years old. IgM levels are very low at birth, slowly rise to mature adult level at 1 year of age. IgA and IgE are not present at birth. Children begin synthesis of these by 2 weeks of age, and normal values do not occur until about 6 to 7 years of age. So, why do kids get sick so very often? Well, because they're not playing the game with full hand of immunoglobulins. They spend the rest of their lives developing active immunity. How? Well, by exposing themselves to antigens. So what ways do children expose themselves to antigens? Poor hygiene, fecal-oral route, and respiratory route. Cell-mediated immunity reaches full function early in life. Children have a big thymus, spleen, and tonsils. Because of the well-developed cell-mediated immunity, blood for children has to be irradiated to prevent graft versus host disease. Okay, let's take a quick review of the immune response. Primary immune response to the first time your body has seen a particular antigen takes about 3 days to wrestle up the troops and mount an immune response. The secondary immune response, you'll get the repeat antigen offender comes back, and this time your body is ready and launches the attack within 24 hours. And then, of course, immunodeficiency. There's primary immunodeficiency. These are children who are born with the failure of the humoral antigen B formation. It's a B cell disorder. It's a deficient cellular immune system. Then there's T cell disorder or combination of the two. Basically, the lack of the immune system is not caused by something else. Secondary immunodeficiency is acquired. It's caused by something that attacks the immune system, such as HIV. Okay, so HIV. The first cases of AIDS in children that were born to HIV positive mothers and in children who received blood products was greater than 90% of these children that acquired the disease from their mothers. Infected blood products and sexual abuse account for a small percentage of the etiologies. The peak incidence of AIDS in children was in 1992 and has been on the decline since then. HIV is spread through body fluids. The virus affects the CD4 T lymphocytes. It basically hijacks the cell and steals the groceries to replicate itself, shutting the immune properties of the cell down. Look at box 43-9 on page 1386 for a list of clinical manifestations of HIV. Box 43-10 for common defining conditions for AIDS in children. When diagnosed in children greater than 18 months of age, it's done by blood tests, ELISA and Western blot immunoassay. Babies born to HIV positive moms will test positive for up to 18 months of age due to the presence of maternal antibodies on board. Babies between 1 to 6 months can be diagnosed by a different blood test. Management is centered on slowing the growth of the virus, prevent and to treat infections. Severe combined immunodeficiency disease. There's an absence of humoral and cell-mediated immunity, aka Swiss type lymphopenic gammaglobulinemia and X-linked lymphopenic gammaglobulinemia. Clinical manifestations: chronic infections, child fails to get over infections, frequently reinfected, infected with unusual agents. Diagnosis is history of recurrent. severe infections from early in infancy, familial history, lymphopenia, absence of plasma cells in the bone marrow. Management. It's from a histocompatible donor or parent bone marrow transplant. IV, IG infusions, and PCP prophylaxis. Looking into gene therapy is a recent theory. This was the disease, basically the boy in the bubble. I want you to go to the website or actually www.cbs News website video that will be provided under the resources link. This concludes all the lessons of Chapter 43.